case study, official case study number 1. You have a 68-year-old male who is admitted with shortness of breath. He reports difficulty breathing with activity, lying down, or while sleeping. He states that in order to breathe easier, he has had to sleep in a recliner for the past week. The patient has a history of hypertension, MI times 2 years ago, and a cholecystectomy 10 years ago. The patient is being transferred to the cardiac progressive care unit for further evaluation and treatment. In the nurse's notes at 1300, the nurse writes, patient arrived to room with transport via stretcher. The patient is A&O times 4. In case you don't know what 4 is, it's person, time, place, and situation. Shortness of breath noted with activity and when talking. Standing weight obtained 155 pounds. BMI is 24. Patient connected to telemetry monitor for continuous cardiac monitoring. Sinus tachycardia noted. And the patient with bilateral crackles in the bases with an S3 was noted. Orders were received. 18 gauge IV inserted in right arm, labs drawn, chest x-ray and echo pending, and the vital signs are as follows. Temp 98.8, heart rate 112, respiratory rate 26, blood pressure 176/98, O2 sats 94% on 4 liters nasal cannula. Pain is a 1 out of 10. And all you are doing, my love, is this first page. Now, there should be a few of you that know how to do this one. We've done this one with the classroom. So it says, question 1 of 6. The nurse receives the patient admitted with shortness of breath. What findings are significant and require follow-up? Select all that apply. Now, before you answer this, do your girl a favor. Take out your Oh My God packet. Let's make sure that in preparation for a case study, you know that even that advice is in here as well. And what I want you to do is turn to page 22. Because I try to prepare you for everything you're ever going to need on this damn test that you're about to take. So it should say next generation NCLEX, NGN, NCLEX case study crap or clinical judgment. Now, here's our deal, everybody. Peep this. You know that there are 8 categories on the NGN NCLEX test plan: management of care, safety and infectious disease, health promotion and maintenance, psych, basic care and comfort, pharmacology, reduction of risk, physiological adaptation. But then there's this extra component that actually helps you out a lot. It helps you out so much you do better in this than any of this put together. So the clinical judgment piece is the case study on your test. And here's the fun part about that. There are 6 parts, but all 6 parts are dedicated to the same exact question every time. On your exam, you may have as many as 150 questions or as little as 85, but no matter where you are in here, you're gonna at least get 3. Check it out. You're gonna at least get 3 case studies in 85 to 150 questions. Now, clearly, if it's 85, 3 makes sense, but they could give you 5 in 85. They could give you 10 in 85. The girl just came out here the other day, had 10. Now, they can be anywhere above 3, never less than 3. So let's use our mind. If you had the minimum, which is 3 case studies, and the case studies are unfolding, sometimes you get mixed up. Unfolding means there's 6 questions to that case study. I want you to remember I said unfolding means there's 6 questions per case study. Because let's say that you have 3 case studies and I already told you you do quite well in them. 6 questions times 3 studies, that's 18 questions you could get right easily. On an 85 question test, when they throw out 15 other questions, can you see why case studies are your best friend? Okay, so when we look at the clinical judgment piece, we have 3 of the 6 that require you think, and then 3 of the 6 that require you act. Watch this. Recognize cues, analyze cues, and prioritize hypothesis, all thinking. You are doing nothing but thinking. You're using your clinical judgment and your critical thinking. Generate solutions, take action, and evaluate outcomes. Those are where you're acting. You have to do something. Stop assessing on those, because you'll get answers that say, assess. No, you are doing something. Does that help a little? Okay, so if you look at this little thing here, we are on question number 1 with question 1 of 6 of our case study. And if you're doing question number 1, it says you're trying to recognize cues, and cues is just another word for clues. And so you're trying to recognize if anywhere in this case study is the assessment regarding the age, the gender, the history, the risk factors, the vital signs, the labs, the test results, the family present or not, medical record review. Is anything in that going to tell you what's going on with this patient? Does that help? Yeah. That's what every single question 1 of a case study. Question number 2 is asking you to take the information that you saw was a clue and take it a step further and analyze it. Watch me do it on a fictional person. If I recognize my case study said 16-year-old female, that was recognition of 2 things I should kind of be like, uh-oh, there it is, female, 16. If I go a step further and analyze it, I would say, childbearing age. I would say, can't give me consent. I would say, in the middle of her growth and development per Erickson. Those are all things that are going to be on that test. Those 3 issues will apply to that question that they just gave you. Does that help a little bit? Okay, maybe let's do one more. Maybe they say you have a 72-year-old who can't remember if they took their meds for the day, but they're dizzy, they don't feel right, they almost fell when they first got up, and their medications include lisinopril, HCTZ, and furosemide. Okay, so you know that the recognition of the cue is that age and the fact that they don't remember. So maybe there's some dementia going on, maybe they don't have a medication planner. Sounds like even could be a safety issue because they almost fell. You see how we're putting things together with it? But really it was all about the age. The recognition of the cue was truly about the age and the memory. And then the analysis of somebody who doesn't remember that's older is that they could have took those pills twice. And the pills that they gave you were really going to cause dizziness and everything else. Does that help a little bit? So I would say to you, as you approach any of these case studies, the gender of the patient, the age of the patient are 2 cues that really might seal the deal for a lot of them. Okay, let's go. All right, let's go together. You do it, and then I'm going to review. You got 1 full minute. You don't even need that long because most of you did it. But let's give you a full minute to see if you can figure out which of these findings require follow-up. And you don't want to use a pencil, you want to use a pen. So I'm going to call them out. Number 1 is heart rate. The heart rate is 112. Does that bear follow-up? Raise your hand if you thought it did. Now don't be a punk or else I'm going to come down your aisle and up your parking lot and slap you. So everybody should have raised their hand because you should have knew that shit was tachycardic. So we are clearly a little stressed because above 100 is tachycardia. We are 112. Yes, you should have chosen that. Raise your hand if you chose number 2, which says the temperature is 98.8. Good. Why would we care about normal temps, right, guys? Okay. Number 3 says pain is a 1 out of 10. Do we care? No, we don't care. When do we care?
At 3.
When it's above 3 or the patient is acting crazy. Okay. Number 4, shortness of breath with activity and talking. Yes. So let me give you some tips on the test, because aren't these patients short of breath anyway? So how do you know when the shortness of breath is too much? I'll give you 3 examples and you want to write them on your little case study. One of them happened in the case study itself. It says while sleeping or laying down. That's one. Another clue on your test is when people say they have to sleep in a chair. That is 2. Highlight those. Those are big on the test. The third one is if you can't even talk. You short of breath trying to talk. That's a big one. So that's your third one. Y'all feeling good about it? Okay, so that was number 4. Number 5, the blood pressure is 176/98. Yeah, I don't like it. Do you? Now, is it at the danger zone that we used on our Oh My God page 7? Let's turn now.
No, but it's pretty close.
No, but it's close. So if you go to page 7, what is the Oh My God, see him first, blood pressure? 180 over 120. Do you need both of those numbers? No, you just need one of them. He doesn't have either of them, but we care about the blood pressure because if you think about, here we go, the physiological adaptation of this patient, you can imagine that if that blood pressure is elevated, what in the human body could cause that? Think it through. It could be kidney failure. Maybe, maybe not, but I like how you're going. What else could cause the blood pressure to be up? I heard it. Fluid volume overload. Excellent. So that's usually the issue with a patient who is what? You said it earlier. Crackles.
Sorry, there is nothing to repeat.
Bet I ain't repeating nothing. Okay, so I tested you on this a little earlier. I don't know if you saw my little test, but I went all up and down your street and down your parking lot with asking you what do you expect to find. Right in here, didn't I? Yeah. And y'all all shouted out crackles. So remember, if you look, don't he got crackles? Yeah. Okay, well, you should have knew right there immediately. Oh, okay, yeah, his blood pressure would be elevated. Because what gives you crackles? Fluid in your lungs. You're starting to understand physiology, right? Okay, good job. Okay, so yeah, we're going to follow that up. Weight, let's see, number 6, weight 155 pounds. No, we don't care. BMI 24. No, we don't care. Because what's overweight? 25 and up. What's obese? 30. What's morbidly obese? 40. Okay. Sinus tachycardia? Yes. Respiratory rate 26? Yes. S3 noted? Yes. That's not normal. You're supposed to have an S1 and an S2. Why are you doing 3? Nobody asked you to put no extra in there. O2 sat 94% on 4 liters.
Yes.
Yes, because what's normal? 95. And this motherfucker's on oxygen. So if he can't even get his pulse ox up and he's on oxygen, you should care. And he's on 4 liters. Okay, so it would be like half-ass reasonable if he was 94% on nothing, but he already on oxygen, ain't doing right. Y'all feeling me? History of cholecystectomy. What's a cholecystectomy? Gallbladder removed. Do you give a shit?
No.
No, because it has no bearing with shortness of breath, no bearings with crackles. It didn't just happen. It said in the actual case study that it happened 10 years ago, but let me switch the game up on you. If I said it happened 3 days ago, it would be pertinent because that crackles might be pneumonia post-op. You see how we switched the game? So what did I tell you in the boot camp? I told you time frames matter. When you get a time frame, that's a cue. The fact that he had a cholecystectomy 10 years ago was a cue. Because if you said 10 days ago, then we got to look at brother having post-op pneumonia. Okay? All right, let's do page number 2, babies. This is question 2 out of 6. And it starts at the top with a chest x-ray result showing cardiomegaly and mild bilateral pulmonary vascular congestion. Then it says that the echocardiogram showed moderate left ventricular dysfunction with a left ventricular, and yes, you better write this, I'll write it on the board first, ejection fraction of 35%. Now here we go, that matters. So peep the game. This guy has an ejection fraction of 35%. What's normal? Anything over 55, right? All of us in this room, we're probably rolling out at 75. Are you with me? Bruh man has 35. So we know that sounds crazy as hell. Then his labs came back. Now let's learn something. The first lab test that was run is called a BMP. Don't confuse it with the BNP. That is not the same. This was a BMP. What does that stand for, everyone? Basic metabolic panel. You need to give a shit. Because everybody and their mother-in-law gets those in your hospital, including every one of y'all patients. A BMP, and take good notes on your packet because it's a great study guide. A BMP looks at what labs, Mr. Gibson? Glucose is one. Give me another one, Nakaya.
Calcium.
Well, you want to sum it up because you got more than one of those.
What did you say?
Want to sum it up? It's more than one. Don't give me one at a time, right? So what is calcium? A type of Okay, so it's BMP is going to give you glucose, electrolytes. What else, Barbie doll?
Renal.
And renal function. I'm going to say that again because you give a shit. A BMP, a basic metabolic panel, is going to give you a glucose, electrolytes, and renal function. It is a mint green tube. What do we do with all tubes of blood we draw?
Inverted.
What is this called? Agitated. How many times?
3.
10. It's on your procedures packet.
You said it's mint green.
It's a mint green top tube. Get you used to doing this because you're going to draw so much blood you're sick. Okay, so that's a BMP. Now, a similar test, so that you're not confused, is a CMP, which was not done, but a CMP is actually a step above. Instead of a basic metabolic panel, it's a comprehensive metabolic panel. It has every single thing that a BMP has, but what did it add? Ari, what did it add? What was added to that CMP? What was added, Shannon? What organ test was added?
Oh, liver.
Liver. Yep, liver studies were added. So if you are told to get a CMP, you know that your patient will be getting a glucose, electrolytes, renal, and liver studies. That's a CMP. It's more comprehensive. It's not basic. So far, so good? Now, so let's look at his BMP. Let's just peep that motherfucker out. The glucose was 98. The sodium was 136. The calcium was 8.9. The magnesium was 1.8. The BUN was 10. The potassium was 3.5. And the creatinine was 1. Was there anything in the labs that I just said that makes you go, ooh, that's interesting? Anything in those labs just for fun, shits, kicks, and giggles?
Sodium, calcium?
Okay, explain your rationale. What are you saying?
The iron, calcium, and sodium opposites?
Okay, you think that sodium and calcium on this patient's lab results is low or high? Where are you going with this?
I think calcium is high.
You think the calcium is high, and what do you think the sodium is? You said both.
Then I guess low.
Low? Okay, does anybody agree with Rogelio that this calcium is a little bit high and this sodium is a little bit low?
No.
Because notice what I did not do, because this is a little bit better and higher learning than the stupid fucking test. I didn't give you normals on purpose. Your test will give you normals, so don't sweat it too much. However, he's asking about a relationship. He said, isn't the calcium and the sodium opposite? So there's a couple things working in his mind. If you look at all of these labs, there's only one that makes me go, okay, that's interesting. But it's not the calcium, because that one's normal. And it's not the sodium, because that one's normal. Which one is it?
Magnesium.
Well, technically they're all normal, but there's one that makes me go, which one would it be?
Creatinine.
The potassium. What is a normal potassium?
3.5.
3.5. But what do we know about cardiac patients? We like them in the 4s. And if you didn't know that, I need you to write it, because if you go work at a cardiac team, they're going to think you're crazy that you don't know that. So we want our cardiac patients to be around 4. Yeah, because, you know, potassium is so bad if it goes down. And it's so bad if it goes up. And we're right at the borderline. Do you see? We're right at the 3.5. So, you know, it just bears what? Watching and mentioning to the doctor, okay? I would mention that one. They're right at the border, doc, 3.5. Now, would I call them? No, because it's not abnormal. Would I communicate this in rounds? Yes. Would I do a chat? No. They'd be, when they come around, I'll let them know. Okay? I don't need to interrupt your day for a 3.5. Don't do that. Okay, y'all good? Now, B and P. It's okay if you don't know this, but you know what it is now. What I do care that you know going forward, and it's okay if you don't know it now, is just that the B and P normal for all of us in this room, and I'm going to go with all of us, and then I'm going to go with elderly. Is that fair? Everybody in this room should be like less than 50. But the elderly are allowed to go to less than 100. Does that help? Who is this guy doing? What's he doing? What's his? 550. Yeah, he doing too much. Now, here's something I will just tell you right off the grip, because you may not know this. When you get these patients in the real world, they're going to be in the thousands. They're going to be 2,000, 3,000, because so many people with CHF have an exacerbation of that CHF, not a new diagnosis of CHF. And when they have an exacerbation of CHF, they're going to be in the thousands. And that will give you some insight as to, oh, okay, they're having an exacerbation. They're in the thousands. It's kind of like a giveaway. Does that help a little bit? So we use it not just to diagnose, but we use it to monitor you as well. Okay. The next blood test, oh, let me just explain, because I should never assume. How and what is this shit anyway? Okay. B-type brain type. B-type natriuretic peptide. And as I explain it, it's going to go over the head of half of you, and the other half will catch it. Don't worry, I'll say it again one day. But for today, I'm going to lose half of you. So just hang in there with me. Brain type natriuretic peptide is going to be your first hint, brain. So when a patient is working too hard at trying to pump their heart, in particular, contract their ventricle, this chemical is going to be released. And also it's going to trigger the fact that they're working this hard is pretty stressful. And it's going to trigger your barometric pressure. And this barometric pressure, barometric pressure is going to be in your carotid and that cerebral artery. Now, you know, over this weekend, that's your brain. And it's going to trigger your brain like, oh, let's get stressed because we're not doing too well. So it's going to trigger the brain to activate the stress response. And as you know, the stress response is going to get you to release some catecholamines, and that's why this patient's blood pressure and pulse is so high. Okay, so it's just another trigger to try to compensate for this patient's inadequacy with pumping their ventricle. Okay, so that's why it's really high